Thank you, Tammy, for inviting me. I'm honored to be with such distinguished speakers. So we're going to talk about planning and indications for high tibial osteotomy, and I think this is, as in most cases, this is the most important part, to have the right indication and how to plan for the operation. We've been taught in orthopedics in general that we have to plan. We usually skip this part nowadays, but in high tibial osteotomy, it is still a mandatory step. So before we start, really, I want to get the audience's view on what would you do in this case. So this, as you see, is evident osteoarthritis, and the options are high tibial osteotomy, unicondylar replacement, or a total knee replacement. So if I can have a show of hands, who would do a high tibial osteotomy for this case? Good question. Good question. That's the question I want to hear, actually. So next, we go to the next slide. This is a 45-year-old male patient who's a manual worker. So obviously, the age made a big difference with you, okay? So you cannot offer a total knee replacement. If he is 65, we'd all agree on a knee replacement. But this patient, you can. He's still got 15 years of hard work. And so we proceeded to do a high tibial osteotomy to this patient. And this is 10 weeks afterwards. Is it possible to dim the lights a little bit on the screen? So, who's the right patient? It really has multi-factors. You take lots of things into consideration, from work, age, culture, job, everything. There's lots of factors to be considered when you decide what's the right operation and who's the right patient. So, indications. The commonest, of course, is genu varum with medial osteoarthritis, adult OCD, osteonecrosis of the condyles, and sometimes we do include them in soft tissue knee surgery with ACLs and genu varum with posterolateral instability. Medial OA being the commonest, usually is done in active young patients less than 60, but as we've seen, it's very variable. Some countries in Scandinavia take this up to 70, and some countries, when I used to work in the UK, it was sometimes 55, 52. So the age is quite variable, depends on your patient, your culture, his job, lots of factors. So this is not a definite number, really what he's going to do. You need a minimum range for 15 to 90 degrees. If he has a higher flexion deformity than that, you won't be able to correct it with high tibial osteotomy, and he will not be satisfied with the operation. So those patients with a high flexion deformity are usually indication to proceed later on to arthroplasty. Relatively mild patellofemoral symptoms. Most of the cases actually with medial OA have some degree of medial patellofemoral osteoarthritis. And when you correct that, you deload the patellofemoral joint, so that does improve to a degree. But you have to explain to the patient that they may not improve as much as the medial compartment. So what are the contraindications? You have to remember, when we're doing a high tibial osteotomy, we're actually causing a fracture and we're causing a gap. And you want the best bone healing available. So smokers are very bad patients, and I stress that with them, that this is going to be a failed operation if you continue to smoke. Of course, we're going to deload the medial compartment and get all the load on the lateral compartment. So the lateral compartment has to be healthy, and you can check that with an MRI or with arthroscopy. Symptomatic patellofemoral joint, as we said, the degree, is it mainly patellofemoral problem or is it mainly a medial problem? Inconsistent pain. Sometimes you have the classic picture of a medial genu varum osteoarthritis, but he doesn't have any pain in the medial compartment. So you have to be wary of these patients. The improvement may not be as good as the classic ones. Inflammatory arthritis affects the whole joints, so you expect that the lateral compartment will be affected in a short time. Obese patients, really, we consider them as a bit of a higher age group. So if you've got a 50-year-old obese patient, then you might consider them as a 60-year-old. So then you have to redo your calculations. They do not do as well with high tibial osteotomies. And these patients, you can take the arthroplasty to a younger age. Flexion, deformity, and range of motion we spoke about. And always remember that you're deloading the medial compartment, you're transferring the load to the lateral compartment. So if the lateral meniscus is not there, that means the lateral compartment will wear off very quickly. Remember that the lateral meniscus bears 70% of the weight transmitted in the lateral compartment. So if you've lost that, you have minimal contact and the pressure area increases. So how are we planned? We've decided this is the right patient for high tibial osteotomy. How are we going to plan this? Several questions you have to ask yourself. Number one, where is the deformity? Is it tibial, femoral, or both? Second thing is the axis. How are we going to measure? Are we going to use a mechanical axis or the anatomical axis to measure? How much correction do we need to do? What are the implants and where are we going to put our implants? And are we going to use bone grafts or bone substitutes or nothing? So we start with the first question, and of course the first key part to do is you have to do the standing long leg films. This is the best way to get a proper pre-op planning, and we have to check the lateral compartment, as we said, with MRI or whether arthroscopy may be in the same sitting. So if you measure the axis, we have mechanical or anatomical axis. For the femur, it starts from the center of the head and goes to the center of the knee. And for the tibia, the mechanical and anatomical axes are almost the same. So for practical reasons, we use the same line, which is mid-tibia to mid-ankle. But for the femur, it differs. Mechanical is from the head to the center. Anatomical is along the shaft. Okay? Next is, where is the actual deformity? Is it tibial or femoral? And that really depends. We have certain angles which we know are the normal values. And if they deviate from that, then we know there's the deformity. The proximal medial proximal tibial angle is around 87 degrees plus or minus 3. We have the anatomical lateral distal femoral angle, which is here with the anatomical axis, and that's about 81. The joint line convergence is actually a range of 0 to 2. And the mechanical lateral distal, so we get the mechanical axis with the joint line, and that's roughly 88, so 88 to 90 degrees. So if we measure on this case, we have the anatomical measurement, we have the tibial, we measure the lateral distal femoral, which is 82 degrees, which is within normal range. We look at the medial proximal angle, which is 81, and that's off. So now we know that the deformity is tibial, and that's where we're going to do our osteotomy. So it's a tibial osteotomy, not a supracondylar osteotomy. But let's look at this patient. So this is the mechanical axis of the femur, mechanical axis of the tibia. If we measure the mechanical lateral distal femoral, it's 100 degrees, and that's off over 10 degrees. The joint line convergence is open, means there's even soft tissue laxity. And also the medial proximal tibial ankle is in varus. So we have a femoral deformity, a soft tissue laxity, and a tibial deformity. You have 3 deformities you have to correct. Now, you may decide in a lesser degree, if you have more than one deformity, to correct them at one site. But such a high degree of angulation, then you'll be causing problems. And therefore, this patient needs a high tibial osteotomy and a supracondylar femoral osteotomy at the same time. So, anatomical axis. We know now where the deformity is. We want to know how much do we need to correct. If we measure with anatomical axis, we know that the normal femorotibial angle is about 5 to 7 degrees in vulgus, more in females. And if you have osteoarthritis, you don't want to get the patient to the normal, but you actually want to deload the medial compartment. Therefore, you're putting another 3 degrees of overcorrection. So to calculate in this patient, we have 6 degrees of deformity, plus the 7, which is the normal, and then we have 3 degrees of overcorrection, giving you a 14 degrees of correction. This will eventually get you to about 10 degrees of valgus. If we measure with the mechanical axis, so the normal is from actually 0 to 2 degrees of valgus, and that gives you load of about 75% of the weight going through the medial compartment. If it's a straight line, 60% is passing through the medial compartment. 4 degrees, it's 50-50. And then to unload the medial compartment, you need your mechanical axis to be deviated 6 degrees valgus. So this is our target if you have a medial osteoarthritis. So on this patient, you measure the current angle and then you add 4 to 6 degrees according to the degree of osteoarthritis. But then Fujisawa came and he said that all these angles are a bit confusing. We're measuring too many angles, we're adding numbers, and this is becoming too much confusion. So he said, I want to measure one angle, and this is my angle of correction. And he decided that he will use the mechanical axis of the whole limb, and he decides where he wants it to go. So this is the current mechanical axis. It's called the mechanical axis deviation. And he said, well, I want the mechanical axis to be about 30 to 40% on the lateral tibial plateau. And that number was modified later by Jacob and Murphy. And they said, really, you shift the mechanical axis according to the degree of osteoarthritis. So it's a full-blown medial OA. You take it 40%, less degrees, it's less deviation. So what he does is, he decides where the mechanical axis wants to go. So he said, I'm going to put the mechanical axis here. Then he draws a line from the femur, line from the tibia, and he just measures that angle. And that angle includes the normal plus the required corrected angle. So there's only one angle to measure, nothing else. That gives you the final angle. So it's a much easier technique. And this is the final result. If you look at the mechanical axis of the femur compared to the tibia, that's about 4 to 6 degrees of valgus. But if you measure one slot from the from the head of the femur to the ankle, the mechanical axis is passing in the lateral tibial plateau as planned. So we know how much we want to correct. How are we going to apply that intraoperatively? It used to be that for the first 10 millimeters, every degree of correction you can do by 1 millimeter of wedge opening. So that gives you an idea how much wedges you're going to open and how much you can, which will use. But when you go above 10 millimeters, the angle is less. So a 40 millimeter wedge will give you a less degree. But now we started using intraoperative C-arm, and this gives you a much more accurate operation and really getting the angles correct. So you pass a line, usually you can use the diathermy cable in the operation, from the center of the head to the ankle, and that will give you the mechanical axis, and it will show you how far it's gone, how much is deviated. Of course, navigation is coming strong into orthopedics, and it gives you very accurate measurements, and then you can calculate exactly where your axes are passing, how much correction you need to do. So after that, how are you going to fix? Of course, we used to use the spacer plates, the poodle-like plates, and then the locked version came out, and then of course the longer lock T plates like the Tomofix and others. Now, the long ones give a much better strength, and biomechanical studies have shown that these are the strongest. And we've shifted from these to these. We didn't go to the locked short ones. And we had a reasonable number of complications with the short spacer plates. And this is completely plummeted when we started using the locked T plates. The complications of lateral hinge breakage, intra-articular fractures, loss of correction, all of these have almost gone once you start using the locked T plates. What about bone grafts? Traditionally, we use them for structural support, and that's not needed anymore with the locked plates. We also use them for biological reasons to improve healing, and some people use bone substitutes. But recent literature we published last year is we stopped using bone grafts, and other authors have shown the same. They used locked plates, and they don't use any bone grafts. So personally, we've stopped using them for more than 2 years. This is an example. This is immediate post-op. This is 6 weeks later. You can see the gap filling very quickly, and this is at 14 weeks, and the patient is fully weight-bearing with no pain. So in summary, really, you have to choose the right patient, and you have to decide whether the deformity is tibial, femoral, or both. Plan which axis you're going to use, how much correction you're going to do, and how you're going to measure it intraoperatively, what your implant. And of course, as we said, you don't need bone graft, but I would like to hear the opinion of the panel at the end about bone graft. Thank you very much.
Thank you, Hatem. You have now